Hi, Dr. Brian Kaufman, a retired family doctor and CLL patient myself, the co-founder, chief medical officer, executive vice president of the nonprofit CLL Society here at ASH 2024 in San Diego, California.
Hello, I'm Dr. Christopher Pleyer. I'm an associate clinician at the National Institutes of Health in Maryland.
Dr. Pleyer, you've done a lot of research in CLL at the NIH in a number of areas. But one of the papers that's being presented that you're the lead investigator on was, I thought, pretty important in it. We spent a lot of time looking at what's the best combination. You know, which drug should be used, is it a doublet, is it a triplet? But you looked at an equally important question. What's the best order to put them in? Are there safety issues? Should we be, you know, it's always been assumed to do it this way, but maybe a different way would work. So give us a little background on what's going on here, how these medications interact with each other, and why you chose what is not the typical order, at least in the US, of doing some of these medications.
No, absolutely. No, thank you. And I think traditionally, what we've been doing is that we've been giving the anti-CD20 therapy, either rituximab or obinutuzumab.
These are the antibodies,
The antibodies, exactly. Those are typically given as infusions once a month for 6 months. And many physicians in the US start off with those drugs before moving on to adding on the Venetoclax. And the reason why this has been done, because we were worried about the risk of tumor lysis syndrome in CLL. Venetoclax is in fact so effective at reducing the CLL burden and killing those cells is that it can overwhelm the recycling machinery and can cause this tumor lysis syndrome. And that's why many physicians prefer to reduce the burden of the CLL with the anti-CD20 therapy upfront and then move on to Venetoclax, where we thought that the tumor lysis syndrome will be reduced.
And there's these, clinicians have this high risk, medium risk, low risk, and we've heard that by doing this you can move patients from medium or high risk down to low risk, and so it's safer.
Exactly.
But your research looked at doing it in the opposite order.
Right, yes, we did it in the opposite way, where we wanted to start with Venetoclax. And part of that reason is because of the two drugs, we know that Venetoclax is really doing the heavy lifting and is doing the majority of the work in reducing the CLL and getting it into a deeper remission. The infusions do add some value and they likely deepen the remission, but the Venetoclax is really the main drug. We thought it would be good to start off with the Venetoclax beforehand, and we're also interested in just seeing whether we do see a signal whether there's increased risk of tumor lysis syndrome. And in fact, when we did this in patients that were both treatment naive, so had no prior treatment for CLL, or patients that had already progressed on prior treatments, most of them on Bruton's tyrosine kinase inhibitors, that it was in fact safe and that patients tended to do very well, and we saw very low rates of tumor lysis syndrome. And they were in fact really in line with what we've seen in other studies where they do it the other way around.
And I have to ask, we talked about this, would this be true for people with bulky disease or high absolute lymphocyte counts? Because there's all these scales that you look through, and if somebody's absolute lymphocyte count is very high or they have massive lymph nodes, that gives you a little bit of a shiver, you know, when you start on the Venetoclax. So did you have some of those patients?
That is a good question. We definitely did have some patients with bulky disease, and then in the high risk category where we had to actually admit them per the guidelines and per the package insert, and we did that. And in fact, those patients also tended to do quite well. We do have to be a little careful because the study is relatively small, so it's hard to make definitive conclusions. But overall, we really did not see any signal, and all the patients that did have tumor lysis syndrome, those were only 2 patients out of the 50, they actually did not have high burden of disease. They were in the medium tumor lysis syndrome category.
And when you said they had tumor lysis, is this just findings on the labs, or do they actually have symptoms with fevers and
No. So
things?
I think that is extremely rare. We had no effects of clinical tumor lysis. This was all laboratory, so all these patients would not have known that there are some abnormalities in the labs. And truthfully, this can happen with frequent laboratory draws. It's not unusual to see some derangements in the electrolytes, and all of them were relatively mild and could really resolve very, very, very quickly.
Is there any, and I know this wasn't the purpose of what you're doing this, but any efficacy data on if it makes a difference, what order you do things in?
Yes, so this was not a randomized, or this was not a comparative trial. So the comparisons that we take are looking at other studies. So we always have to be a little bit careful when interpreting those results. But they look really quite encouraging. Are very much in line with the Murano study, which is really one of the first and larger studies that looked at this combination, where the 2-year progression-free survival, which means that at 2 years, how many patients have progressed, was only 15%. So the PFS was 85%, but what that in practice means is that at 2 years, 15% of patients had progression of their CLL, and that was exactly what we saw in our study. One thing to maybe note on that is that the Murano study is several years old now, and not as many patients had been on a Bruton's tyrosine kinase inhibitor before going onto that treatment, whereas in our study, the vast majority of patients had actually progressed on a BTK inhibitor like ibrutinib or acalabrutinib. And we know from more recent studies that those tend to be patients that have a shortened progression-free survival as well. And we were very encouraged to actually see that our numbers actually look pretty good and are comparative to what we've been seeing with the older studies where patients hadn't been as heavily pretreated.
So a more difficult group to treat, but the results ended up the same.
Mm-hmm.
And there's been some earlier research suggesting, especially with antibodies, not so much with small molecules, but with antibodies, the drug to target ratio, is very important, both in terms of adverse events, but also in terms of efficacy, because there's only so much rituximab or obinutuzumab to hit the CLL. So that can be an issue. So it would seem like almost there would be a therapeutic advantage to doing it in the other way, where the reduced tumor burden from the Venetoclax would make the rituximab more effective. Am I just dreaming this, or is this something that makes sense and can be looked at?
No, I think that is a very astute observation. In CLL, particularly at the time when it's progressing, we have billions and billions of CLL cells that need to be targeted, and there's only so much antibody that we're giving. So in patients that have particularly high burden of CLL, we are likely not giving enough antibody to target all of the CLL cells that are in the circulation and in the lymph nodes. And by doing it the other way around, where we actually give Venetoclax first and get some control of the CLL, we reduce the burden of CLL, and then we come in with the antibody, and then the antibody can potentially do its job more effectively because it can bind all of the cells it needs to.
I'm very excited about this. Any final thoughts or takeaways you think from patients in terms of this, just kind of not just going with the common way of doing things, but looking at stuff in a different way? That's...
Yes, I believe this opens up the possibility that it can really be a more informed discussion between the physician and the patient, and they don't have to worry too much about the exact sequence and can do it what they feel works best for them. So I think there's more option for the patients, which is always very, very, which is always, I think, really good. The other thing that as part of the studies, we did have a lot of engagement with our local community oncologists. The way how we set up the study is that at NIH, we took care of the patients for the first 5 weeks of the Venetoclax ramp-up, which is typically the trickiest because it involves a lot of monitoring, and then transition them to their local hematologist or oncologist. And we had a very good relationship with them, and they felt, both patients and physicians actually felt quite reassured because they could give us a call. So I think this was also a great example of how academic centers can collaborate with the community as well.
Dr. Pleyer, thanks so much for the research and the care you and your colleagues at the NIH are doing. It's very exciting.
Thank you very much, and thank you so much for all the work that the CLL Society is doing. It's really wonderful working with you over the last couple of years and seeing what you've done, what you're doing for patients, and we hear from you in our patient rooms as well. So thank you very much for all the work that you and your team are doing as well.
Thanks so much. Thanks.